Well, why don't we go ahead and get started? I know people are still logging onto the call, but I'd like to welcome everyone to our webinar today, The Role of Technology in Value-Based Care and Patient Engagement. My name is Claudia Ellison, and I'd like to welcome the participants and also provide just an overview of what we're going to be discussing today. We're really thrilled that we've got such a fabulous lineup of speakers for this afternoon. Just in the current environment of value-based care and for many other reasons, it's really important to be able to share information, patient information in real time. It's not always easy to do this, and we've got things like pre-authorization, we've got different EMR technologies, but eHealth recently conducted a series of executive interviews to better understand how these things are how patient information is being accessed and sharing data with other providers and payers. So in today's webinar, you'll hear the results of those interviews, followed by a panel discussion with industry thought leaders. We've got our eHealth's own Nkosi Wills, who's our program and communication specialist, and Nkosi will be providing that overview. And then we're going to have a panel discussion led by Jeff Chester, who's the Senior Vice President and Chief Revenue Officer of Availity, Taya Mohesier, Director of Health Policy and Product Development of HC3, and Charlotte Hale, System Director, Admission Services and Central Access of Cox Health. So before we get started, just a few housekeeping issues. All the participants are muted. If you have any technical difficulties, you'll see on your computer two areas to communicate. One is the chat box, and then one is the Q&A. When you do have a question, please use the Q&A feature. This provides an opportunity for our panelists to actually better see your questions and respond to them. And we save these questions, so if we don't have time to answer all of them, they're saved and we can get back with you later. We do have today's slides, press release, and report available to be accessed on our resource page. And throughout the webinar, we'll be letting you know exactly where you can access this. Just a little bit about eHealth Initiative. Our mission is to serve as the industry leader, convening executives from multi-stakeholder groups to identify best practices to transform healthcare through the use of technology and innovation. We conduct research, education, and advocacy to support the transformation of healthcare. And we do this through webinars such as this one. We conduct several executive roundtables over the course of the year. And we also use our membership actually to support the work that we do. We have a fabulous group of members, such as Availity. We've got AMA, PwC, United Healthcare, and you can see from just this small snapshot the scope and the multi-stakeholder approach that we have. Also, along with the webinars and roundtables that we conduct, as part of our membership, we have work groups, value and reimbursement, data analytics, workflow, and over the course of the year, we'll be doing a deep dive into these issues and come up with, as we do research and come up with best practices, we develop industry and policy recommendations. We put a lot of this information on our resource page, and you too can access the resource page whether you're a member or not. And you can also add information to this page if you'd like. It's a very easy process. You can find the link, add your information, and then we post it. So it's a really fabulous way of sharing a wealth of information to the HIT and healthcare stakeholders. And we couldn't do these programs without the support of organizations and companies such as Availity. So we really thank them for our webinar today. And on that note, I'd like to turn this over to Nkosi Wills, who's going to give you an overview of the research project that was conducted. Nkosi?
Thanks, Claudia. Hello, everyone. I hope you're enjoying your afternoon. My name is Nicosi Wills, and I actually spoke to the executives that we interviewed for this project. Next slide, please. Alrighty, so in October and November of last year, we convened the folks you see on this slide to ask them a series of questions about what's going on in their specific organizations. How were policies, specifically value-based care policies, having an effect on the technology that they were deciding to use, and ultimately how these decisions were playing out in their revenue cycle. As you can see from the slide, it was a variety of different organizations represented. We had William Borden from GW, he's their Chief Quality and Population Officer and a professor. We had various health information networks represented, and it was a good representation of executives from throughout the country. Ultimately, we asked about how policies, consumerism, patient engagement strategies influence provider decisions around technology, and what organizations were planning to do in the next 12 to 18 months. Next slide, please. Okay, so our technology-based questions fell into about 5 categories, and here are some of the highlights. So in terms of value-based care trends and their impacts on technology, definitively value-based care is changing things. It's changing how people conceptualize, collect, and analyze data and how their institutions are running. Making that leap from fee-for-service to value-based care has been a transition for everyone, and data and analytics are really a priority. There is no roadmap for making this leap. So organizations have been figuring things out, trying to see what works for them, what doesn't. One of the biggest themes throughout the interviews and subsequently the report was the importance of EHRs and making sure that the electronic health records have the tools necessary for folks to do the work that they need to do. Population health analytic tools were a big area that organizations want to focus on. Providers were also looking for tools that will help them with MIPS, APM, CMMI, MACRA, CPC Plus programs. People really needed the tools to help them implement what they saw fit. In terms of adoption of technology, they wanted tools that would track and manage patient flow and admissions, tools that specifically dealt with acute care management, tools that documented outcomes and enabled providers to have more time with their patients. And once again, back to the tools that ultimately improve their EHRs. Next slide, please. So the other technology topics that we covered, we asked folks about how they preferred their resources, in-house, outsourced, consolidated, and a third of our interviewees, and once again there were 12, said that nothing has to remain in-house. As long as it's a solution that provides the greatest patient experience at the lowest cost and the most amount of accuracy, it should be explored regardless of where it's housed. Some interviewees definitely fell into the camp of some things should stay in-house, such as their EHR. And ultimately, it boiled down to preference. Integration and collaboration was also a very big theme in this particular section of the report. One provider specifically said that in their region, Epic was essentially the only game in town. So the providers got together and they decided how they wanted Epic to look like and roll out. And from that meeting and from that coalition of folks, they were able to influence the product in that area. So, and it would not have been as beneficial if everyone just worked in a silo. In terms of current use of technology, people are using various patient portals, doctor portals, various EHR systems, mobile health software, HL7 messaging, clinical data exchanges, population health tools. Again, people are very interested in this and are exploring all sorts of population health tools. Over the next 12 to 18 months, predictive analytics is on everyone's radar screen, and how can we use predictive analytics to essentially help with better outcomes? One organization specifically is looking at genomics. They have a project where genomics is going to be very beneficial in their clinical work. And folks said that document and patient management tools were definitely something that they were looking to invest in as well. Next slide, please. Topics that were not specifically technology related included the impact of consolidation. More than half of the interviewees were affected by provider consolidation, and in certain regions of the country, provider consolidation is having an effect on just the number of physicians available to practice. Vendor consolidation, folks were experiencing this as well, where vendors were, they would be working with one vendor and then that vendor would get sold to a larger entity. And so then there'd be some challenges around what's going to happen next. So these types of consolidations are definitely having an effect on the people that we spoke with. In terms of the provider consolidation, everyone we spoke to said if they weren't going through provider consolidation at that point in time, it had already happened. So that's definitely playing out throughout the country. Consumerism and examples of patient engagement. This was a large section of the report, and the consensus was patients definitely want to engage on their own terms, whether they want to have access through iPads and cell phones, the computer, whether they want evening appointments, whether they want transparency about how much they're going to pay up front. They want to engage the healthcare system on their own terms. So with this move towards value-based cares, providers are increasingly seeking solutions that can enable this type of engagement. So our interviewees spoke about eVisit, a hospital home system that's mentioned in the report. They were exploring online scheduling, having a book now feature through social media, and definitely still employing surveys and questionnaires and some of the more traditional ways they've engaged patients. At the end of the day, consumers are shopping for health services and they're interested in convenience and cost. So we just have an age of more educated consumers. Next slide, please. So in terms of pre-service innovations, we specifically asked folks what was missing from pre-service innovations. And we defined pre-service innovation as the things that you would engage your patients with before they actually had a visit at the doctor. One of the respondents did say, in his opinion, pre-service innovations was a misnomer, and every time you interact with the patient, it is a service. So I thought that was an interesting comment. Standardization was one of the things that was noted. Taya, who's on this call, specifically said that having a checklist type of process would be helpful so folks can get on the same page about what's out there. Other solutions that they wanted to see were those that just met the needs of both the payers and the providers, having better systems for pre-authorizations and for referrals. So currently, folks just seem to be generally unhappy with the whole referral process and thought that that could go a lot more smoothly, and technology could be used to assist that. Tools that help patients share their own clinical data. In one example that was given, sometimes patients show up and there is no EHR data. So they come to an appointment with literally nothing. So the doctor has nothing to work with. So having some type of system that makes it easier for patients to share their own data on the spot or whenever or wherever they want to share it. And price transparency, that was a very big issue, especially in this increased consumerism age. Patients want to know what they're going to pay. Providers want to know what things are going to cost. And there's always a trickle down. If you go to the doctor and they prescribe a medication for you and it's way outside of your budget, you're not going to get that medication. So if you can know these things in advance, then your doctor can make different decisions. So all of these are part of that price transparency. We also asked about boards, patients, and interviewees. So we asked our interviewees what their perception of what their boards wanted, what patients wanted, and what they wanted for themselves. And the biggest themes were access to care, data analytics. Board of directors specifically wanted to see their organizations progress, but progress in a manner that was fiscally secure and in line with their strategic plans. One interviewee said, quote, "America has the most expensive health system in the world because there's so many layers of overhead that require constant tweaking." So fixing that would also be a great thing. Next slide, please. All righty. So that concludes my part of this presentation. As Claudia stated, the full report is on the website. Our press release is on the website. If you have any questions or comments, let us know. We're totally reachable. All righty. Jeff Chester is coming up next, and he is the Senior Vice President and Chief Revenue Officer of Availity. Thank you for listening to me.
Thanks, Nkosi.
Thank you so much, Nkosi. Hi, everyone. I'm Jeff Chester, yes, Chief Revenue Officer and Senior Vice President at Availity. I guess, Claudia, sound check. I assume you can hear me okay?
Yeah, perfect. Thank you.
Okay, great. So for all those out on the webinar, what we'd like to do over the next 20 minutes is, starting with me, have each panelist, so Charlotte and Taya, share a little perspective on what they gleaned out of the research based on the roles they have in their organization and their perspective on the industry. Talk a little about their organizations. And then after that, we're going to do a little Q&A, and I've got some questions to go back and forth with the panelists on. And we want to give you all an opportunity to pose some questions. So if questions come up as we're doing some stuff with the panelists, we'll take them, or we'll reserve some time at the end for questions. So we want to make it interactive. So again, I'm with Availity. If we want to go to the next slide. Real quick, I don't want to give everyone here an Availity corporate pitch, but for those who aren't familiar with Availity, we've been around for about 20 years. We've become a centerpiece for how data is exchanged between health plans and providers. In 2018, we'll do well over 3.5 billion transactions between plans and providers. We have over 1.5 million providers registered with Availity. We'll have over 500,000 unique logins today for people that are providers that are engaged in Availity to interact with their health plans. You know, what we get up and do every day is really have a mission to make it easier for providers and health plans to engage and exchange information, exchange data, with a goal of eliminating the administrative waste. We feel like if we can get that right, we can help drive down the cost and improve the quality, which we all know are really important points. And we don't think there's ever been a more important time to get more efficient and effective engagement between health plans and providers. So just a little bit of an overview on Availity. So let me share with you some of the things that I took away from the research, then we'll let Charlotte and Taya do the same. I spent a lot of time out in the U.S. healthcare system talking to provider leaders and health plan leaders and the folks that are charged with implementing the critical initiatives. And I think this research was very consistent with some of the inconsistencies I see in my day-to-day interaction. I mean, a lot of plans and our providers and the provider leaders are all doing things a little differently. There's a lot of similarity, but there's so many things that are market-based, and what plans are you working with? Are you taking risk? But there are really 4 points that I pulled out of this that I think are pretty consistent from what I see every day. One is consolidation has had a significant impact over the last decade. Most providers have become either employed by IDNs and hospitals or parts of large provider-owned organizations. The solo practitioner world has really become very small. And it's just the complexity of being a solo practitioner in a small group practice has become very difficult. But as we've seen this consolidation, we've seen another version of consolidation, which is around the IT assets that these providers have had. And a lot of the consolidators have tried to standardize on a single HIS or EMR or accounting system. And typically the EMR has been the focal point of that. And those who haven't been able to get to a single system have at least got down to, or tried to get down to, the meaningful few EMRs. And we expect to see more of this. And we think many CFOs and CIOs, and what I gleaned out of this research, are trying to get down to fewer vendors that can do more. Which brings me to my next point that I pulled out of this research is there is a lot of talk in the research and points around the EMR's role. And there's a desire for the EMR to be the workflow engine, to receive the analytics. For example, it's alerts and gaps are talked about, population health. I mean, the EMR is seen as the workflow and the foundation of engaging between plans, providers, and consumers today. But I think what's interesting as I read this research is different commentary, and this gets into my inconsistency, is what is the long-term platform going to be? Is it going to be the EMRs, and there's recent research out there around what EMRs are gaining market share, and it is a handful of them. Are the EMRs going to expand into population health and AI and machine learning and patient engagement? Or is there going to be a wave of best-of-breed solutions that sit on top of the EMRs? And as you read the research, there's different opinions around what's going to happen there. And it will be interesting to see over the next several years how that plays out, because when we look at FHIR and interoperability, that's going to be really important. But whether we have, the enterprise vendors growing and expanding their capabilities, or we have best of breed, will kind of change some of the demands we have around interoperability and standards. The next point that I think was very powerful in the research was around consumerism. There's no doubt consumerism is probably the most acute driver when we look at value-based care. The dialogue and section around point of service, pre-service, meeting patients where they are, like Nkosi said, giving them transparency, helping them understand their financial responsibilities, giving them choice is well stated in the research, which is something I hear every day, again, as I'm out talking to provider organizations. What I thought was really fun, I guess, to read in the research, and I didn't expect it, was a lot of dialogue around like alternative scheduling. And I think Nkosi mentioned this, is meeting your Medicare patients where they need to, really do their business during daylight hours, where, working folks are trying to get in after hours or on weekends. And there's talk around alternative scheduling and meeting patients and consumers where they are. And the other thing I thought was really interesting is the conversation around piloting televisits, telemedicine, and home health, and how we then will exchange data and support value-based care as we move care to new settings like televisits and home health. And then the last thing I'll say, and then hand it off, is, one thing that really dawned on me as you read through the research is all the complexity and, the EMRs and population health and artificial intelligence, machine learning. We're an industry that's going through this massive overhaul in our payment models. Yet the predominant payment model is still fee for service. And we're asking these provider organizations and these leaders that were responding in this research to make this move. And it's really challenging the capabilities of their organizations, whether that's technology, human resources, or financial resources. There's a lot to unpack in what's happening in the U.S. healthcare system. I think this research was really fun to read and gave us some great insights. So that's a little bit about my organization, Availity, and some of the things that we pulled out of the research. I don't know if it's Charlotte or Taya that's up next, but we'll hand it off here to Taya.
Thank you so much, Jeff. I just want to check real quick that everybody can hear me okay.
Sounds good.
Okay, perfect. Well, thank you so much for having me. So I am the Director of Health Policy and Product Development at H3C. And so they asked me to discuss a little bit today about what it is that we do at H3C, because what we pulled a lot from the research that Nicosia has provided here is that there's a great desire to adopt new technologies and utilize that to help stratify data and do some predictive analytics, do some things to quantify social determinants of health and use that as a resource for driving care delivery. And so there's a lot of those things that we've incorporated into what we do here. So I just wanted to talk about this a little bit and show you guys what it is that we're doing to try and help support that. So at H3C, we're an organization that provides remote patient engagement and clinical support services to providers and clinics to help them achieve value-based care success. So we actually operate as an extension of existing care management teams, or we help set that up. And we have varying levels of programs. Basically, the goal is a lot like it spoke about in the research. Not everybody's going to want to outsource their program. Some people are going to want to keep it internal, and some people are going to want to outsource temporarily until they can bring it fully internal. And I think that you really need to see more organizations building that level of service so that it does vary dependent upon what the clinic actually needs. We are CMS connected care partners, so we do provide a lot of education, kind of pride ourselves on the adaptiveness of those processes. So we do provide services like care management services, annual wellness visits, and things of that nature to meet CMS requirements and best practices. And really the goal is to help identify care gaps, help close them, identify patient satisfaction and ways to improve it. One of the things that we talked about when we were actually speaking back and forth with Nicosia is that there's a lot of opportunity here to help identify care gaps for providers because they don't necessarily know how to use that data to best service them. One of the doctors that I first worked with when I first got into healthcare told me, I went into medicine to learn how to help people. I didn't go into medicine to learn how to run a business. I'm going to need some help with this. And so that's kind of what we do. So, if you would be so kind to go to the next slide, please. The way we do it is it's kind of how you're talking about in this presentation that eHealth has put together. You really need data from a lot of different places. It's got to be flexible. You've got to be able to manipulate that data and move it around. And so that's what we do. We've built this robust platform so that we can integrate discrete data so that we can use that, extract that clinical data, the claims data, and anything else, put it into something usable, load it into our enterprise data warehouse, and then automate the workflow algorithm so that we can identify, patient attribution, risk stratification, build cohorts out of these patients, and things like that. And the reason you want to do this is to help build profiles of patients so that you make sure you're getting to those patients who need the help at the time that they need the help and getting them the right kind of help or getting them to the right place. One of the things we talked about, or at least it was brought up in this research that was performed, is that a lot of providers want to do value-based care, but they don't know how to go about it, and they don't know what technologies they need, or they're moving under the assumption that their EHR is a data analytics warehouse. a lot of times when I come into clinics, what they have is basically a data repository, a documentation station, if you will, and it's not an analytics tool. It doesn't allow them to identify care gaps and work with patients in the way that they're thinking. And I know we're going to get into more of this with the Q&A, but I really, truly believe this is very useful research. I think this is where the industry is headed. To Jeff's point, this is a turbulent time in healthcare. Lots of things are changing, and I think in order for us to really succeed, we're going to have to integrate and start working collaboratively and make sure we're getting the data from multiple sources and then using that to really drive care delivery.
Thanks, Taya. Charlotte?
Hi, I'm Charlotte Hale. Can everybody hear me okay?
Yes.
So I'm with Cox Health, and so a little bit about us. I included a few slides there. We have 5 hospitals within our system, and you can kind of forward through. I just gave a little bit of brief history about us. Some of our campuses there. In the middle is how we started with the Cox family. But 5 hospitals, 2 which are critical access hospitals, a little bit smaller, but we are a community-based, not-for-profit health system, and so dealing with several different communities and different areas, and so my staff, of course, are all the upfront staff, admissions, scheduling, and so my big focus, of course, is patient experience. That's my huge passion. So this article was very interesting to me as well. Like Jeff said, there's a lot of things that really hit home with me, the pre-service engagement, the piece especially, you know, all those are big things for me, the authorizations, how to kind of make that all easier for us, because those pieces are really hard for our staff to make sure that we have that in place and make that more streamlined for us. But the patient experience, I think, is the big thing that sticks out for all of us. And if we do everything right on the front end, of course, the billing and everything at the end is going to be what's really important. And so some of the things that we're doing to contribute to some of all of these things that was mentioned in here, of course, we do the telehealth and we have telepsych visits in some of our more rural areas. We have recently started in our urgent cares with Save My Spots, letting some of our patients schedule of sorts visits during our more downtime areas. Of course, we have some welcome clinics that we have started, and as we've experienced, as I'm sure a lot of hospitals, we have started experiencing less PCPs, and so the welcome clinics, when those appointments with PCPs are really hard to get and takes longer to get into with just those opening visits. And so the welcome clinics, once you have established a visit and it might be 2 or 3 months out, you can get into the welcome clinics, and that might be a nurse practitioner, something along those lines, but that you can get your meds refilled until you can get in with that new PCP when you've moved into the area. So that's kind of a new thing for us that we've established in all of our communities. And then we have a new thing that we started with our EMS service. We have it's called Advanced Practice Paramedic Service, and what they do, the drivers go out and they help deliver meds to some of the patients in our rural areas that can't drive, they're homebound and things like that. So just some of the things that we've tried to do to increase that patient experience and keep them out of our ERs, but still tend to those who are in need for us. And I will let you guys kind of.
Time for some Q&A?
Q&A, Jeff.
All right. So Charlotte, we'll give you a little bit of a break, and we'll start with a couple questions for Taya. And you know, I think for those who haven't seen the research, I mean, analytics. There's a lot of dialogue around artificial intelligence, machine learning. For those of us who have come from HIMSS and you see all the messaging, those are kind of the new buzzwords. So Taya, as someone who's, you know, really has a deep understanding of analytics and, you know, the things that you're doing, and you referenced as you did a little bit of an overview, where do you see analytics today, and where do you know, we always overestimate where we're going to be in healthcare. And I think back to research we did with where value-based care would be in 2018, and we're just really not there. So can you give us your perspective on where we are today with analytics and AI? And I know these aren't totally synonymous, machine learning, and where do you think we'll be in the next 18 months?
Sure, absolutely. So it's kind of a cool time to be in healthcare, I think, with AI being what it is. I read an article the other day about how, you know, to stay current, providers need to read 29 hours a day within their specific specialty, which obviously isn't going to be able to happen. So I think for things like that, AI makes sense. You know, I hear of them using IBM Watson to provide a second opinion because obviously the computer has more time to do those readings. And I think you're going to start to see more things like that pop up. But, you know, I also talk to those providers that say, I'm not going to participate in MIPS or APMs because it's probably going to go away. And that I would caution against. You know, the shift to value has been coming for a long time under the guise of things like meaningful use and PQRS. So it's really not likely to go away anytime soon. I think to achieve success, it really requires knowledge of your patient base, their outcomes and trends in disease and in care, and that requires analytics. You know, so I think over the next 18 months, I think it's going to become essential to understand how to utilize data and how to use analytics and how to use that effectively for your clinic. I think the biggest potential impact, honestly, is going to be those that fail to recognize the importance of looking at the data that they have as a clinical support tool. For example, I know I mentioned it briefly earlier, but things like social isolation and other social determinants of health are being identified as quantifiable factors in patient outcomes. That is so impactful. So providers who are looking at this data now and trending it now to learn how to identify and resolve or use it to prevent care gaps, those are going to be the high performers. And then when you couple that in with people who are using AI to support their clinical decision making, that's really going to take us far. And I'm really intrigued to see what comes out of the industry over the course of the next year and a half.
Thank you. And Taya, a follow-up to that is, I referenced this, and I think it was, there was a lot of dialogue in the research around EMRs being the workflow engine. What's your perspective on where AI lives in relation to the EMR, and does the current environment have the EMR infrastructure to actually act on the AI and analytics that's out there today?
Yeah, I think that's an excellent question. And so what I've been seeing in the industry is you either have an EMR that's being used fully to the extent of its capabilities, where accurate information is coming out and thereby accurate information can be pulled out and trended from and analyzed. And then you have systems where there's no standardization of what's being input into the EHR, and that can be extremely problematic. We are seeing some of the larger EHR organizations that are doing big things. They're trying to integrate with data analytics engines and things that kind of lay over top of their EHR system so that they can pull out discrete data and push back to them the meaningful portions of it. But it's only as good as what gets put into it. So I think the bigger issue that I see right now with using that data to trend from directly from the EMR is that you've got to make sure that it's as accurate as possible. And in fact, a lot of the data analytics organizations I've been talking to will only use claims data or prefer to use it right now because they don't trust the clinical documentation data that's being put into the EMR.
Great. And then one last question on just analytics and data. And, you know, something I've experienced in the industry, again, I've been at this for 25 years. I hate to say that. It's it was fun when I could say I've been in healthcare for 10 years. But fee-for-service had a certain incentive alignment, or maybe even a lack of incentive alignment for collaborating, sharing data, acting on analytics. Do you feel like our current state and kind of the fence we're straddling between fee-for-service and value-based care, do you think incentives are aligned between plans, providers, and consumers to share data and act on analytics? And if not, are we at least on the right trajectory?
Yeah, that's a great question. So sharing data is obviously critical. And providers are reluctant right now. They are very reluctant. I do see payers getting into the mix and wanting access to that data and wanting to help providers. But wherever there's a concern about compliance or the other usage of that data or cost, people tend to be very reluctant. If providers don't know the information is being transported securely, or they're concerned, maybe they're setting up a system which requires reliance on one specific payer, then they get concerns that that's going to reduce their negotiating power, or what will the payer do with this data? When I speak with providers right now, there's still a lot of us versus them conversations happening, which is counterproductive to us trying to get this collaboration on data. That's never going to fully go away. There's always going to be a few us versus them, but we really need collaboration right now. I'm not sure if you've seen what's going on in Maryland. I know I'm not in that region anymore.
Yeah.
I was there for quite some time, but the CRISP system that they have there and the way that they've set that up is truly phenomenal. The way they're getting everybody engaged, the providers, there is no cost for them to participate. They know that the data is secure. And so that level of engagement is extremely high. It's the same with their all-payer model, right? Everybody's at the same table. Collaboration is required in order to succeed. So Medicare is seeing huge cost savings coming out of that state. I think whenever you can get people over those small barriers, like the mistrust that I understand, right? It's kind of historically bred into the industry, that mistrust between payer and provider. But we need to start hurdling those barriers if we're going to work collaboratively enough to shift to value. Whereas, as Claudia mentioned and Nkosi mentioned, there's no roadmap to do this.
Wow. Taya, thank you so much for your responses. So just a couple questions for Charlotte, and we'll go to some open Q&A from the folks attending the webinar. So, Charlotte, I've been fortunate enough to have worked with Cox Health throughout my career, and it's America when you're on the Cox Health campus. You guys have engaged in some pre-service clearance activities. Can you talk a little bit about some of the things you've done over the last, 2 years, as we've seen the new demands from patients, the burden that, higher patient responsibility, financial responsibilities having on hospitals and integrated delivery networks. Can you talk a little bit about what you have done, but also where you think you're going? And there's the vision of, basically patients doing everything like they do in the rest of their lives for their financial responsibilities and interacting with their different suppliers of consumer goods. So can you give us a little overview of what you're doing and where you see? I think you're such a great example of the American consumer and what their demands are.
Yeah. So thanks, Jeff. Yeah, that's a great question. So when I came on board, we really did have to integrate all 5 of our hospitals. We all had some different things that we were doing, and so they didn't have a director. So in all of our admissions area, so big thing, implementing pre-registration and getting all of our centralized scheduling on board. So a huge thing, communication with our patients. They do want to know what they owe, and it needs to be accurate. It's that communication piece is huge. Of course, you guys have helped us tremendously with that. So estimation tools, eligibility tools at the point of service, being able to doing authorizations in a timely manner prior to scheduling, at the time of scheduling medical necessity. doing red flag checks with your patients. Financial counseling has become a huge part of the patient burden is shifting, you know, where we used to have average out-of-pocket expense, a very large portion, you know, we considered a few years ago $1,000, you know, now that's, you know, an average cost for a patient is $2,500 being out of pocket, and so, or more. And so finding, you know, ways to help patients pay that, it's huge for the front end staff and making that manageable for a lot of our patients. And so being able to do presumptive charity prior to services and offering that. So those are all big things for us to keep and, you know, keep managing our denials right at the beginning. So those are all, and still keeping our patient happy, doing all that and being able to keep them smile. So those are all of the initiatives that we have been doing, and with the help of Availity and some other people as well. And then that takes buy-in, not just from our staff, but also from the top down, because you have to have support from as high up as our CEO, our board, and if you do it the right way, your patients, like I said, they do want to know. We don't want surprises at the end when they get a bill.
Thank you, Charlotte, and thank you for that plug on Availity. So let's open it up to some questions, Claudia. I'm not as familiar with Zoom as you guys are, so I know there's some Q&A, sure, and we can always pose a couple other questions if we run out of Q&A from the audience.
Sure. So here's one. Can you break down the key differences between data repository, which may link with other EHRs, and data analytics tools or software?
That's a Taya question, or Taya, excuse me.
Sure, yeah, I'll jump in here. So a data repository, which can link with other EHRs and data analytics tools. So one is going to house all of that information, where the other is really going to utilize it. So and the way I usually reference is think of, pretend you're a chef on one of those shows, right? And you have all of the pieces of your recipe in nice, neat, little pristine bowls, the way that we all do in our kitchen, right? They're all set up and they're already pre-measured and everything looks beautiful. But by the end of it, you can't see the recipe. You can't tell what it tastes like. You can't tell how great the meal is, because those pieces haven't been pulled together yet into a cohesive thing and looked at when they're all together. And what do they do when they're all together? What makes this flavor over here pop? Being able to pull all the data into one central place and look at it and see where it's trended and what pieces are connecting, that's where the data analytics tools and the software really comes in handy. Because those data repositories, which link to the EHRs, and sometimes the EHR is mainly used as a data repository, that has all the information, but it's not telling you what the linkages is between things, what the patient trends are, right? You may have a patient population and notice, hey, you know what, all the patients that we have in this particular region have a high rate of diabetes, and their A1Cs are increasing regularly. It may be that area has low access to nutrition or nutrition education, and then maybe you can tackle that. So you have the data, but you don't have the ability to utilize that for your benefit and for the benefit of your patients without using some sort of tool to help analyze that.
Thanks, Taya. So, Jeff, I have another question. What are some of the barriers for payers to begin using clinical data as well as claims data? Is this a Taya question or a Charlotte question?
You know what? I was on mute. I'll take a real quick response to it, and then let Taya and Charlotte respond as well. But I have a unique role because I spend a lot of time with health plans and with providers, because we have a portfolio that serves both. And from my view is, and this gets into the question that I posed to Taya, I think most health plans are using clinical data. They're using EMR data, but I would say it's not readily available due to just incentive alignment, and I don't know that it's technology as much as it's just, are people ready to share? Is there enough of a workflow, meaning this impacts enough of my patients that I'm going to do another workflow so that I can package this up and move it to the health plan? But I think my view is most health plans are ready to act on clinical data. It's just getting enough of it and enough critical mass of it throughout their networks.
Another question. What is your, and I guess this is both Taya and Charlotte, in terms of the exchanging of this data, what is your utilization of regional HIEs to store and exchange the data?
So here at Cox, we participate with, Missouri has an exchange that we participate in, and are currently in the process of working with Cerner, who manages our health information, EHR. So working with them to utilize theirs as well. And
Sure, and this is Taya. So all over the country, it's going to depend by state as to how much we can work with those HIEs. Now, some have a statewide HIE, some have multiple by counties. There's also some private HIEs which don't allow any outside entities. You have to be a participating provider or payer within that specific little area, that's usually subscription-based. So it really varies widely. We love to work with HIEs because we're able to get the data. We do a lot with transitional care management, so getting the ADT feeds from hospitals are usually a huge benefit to our providers. So we love working with them. It just really varies depending upon how they're set up.
Thank you. So Jeff, I'm just wondering from your perspective, and also Tay and Charlotte, with the results of the interviews that were conducted and the summary, any big surprises to you all?
My biggest surprise was the number of respondents that talked about some of the things they're doing, and I mentioned this earlier, and with alternative scheduling, televisits, home health. And it's not in their pilots, or at least that's what I gleaned out of the commentary. But to see provider organizations starting to do alternative things around scheduling and the setting of care, again, whether that's televisits or home health, I think is really encouraging, meeting the consumers where they're at. I think it was fun to pull that point out of the research.
Taya?
Yeah, I think what I found most interesting was that a third of the respondents noted that, you may need to take things outside of the practice and that's okay. I think if we were looking at this about, 10 years ago, in some cases 5 years ago, you definitely wouldn't have that many respondents say, oh yeah, sure, go ahead and outsource it. There was a lot more fear there, where now there's a lot more engagement and excitement about looking at that as an opportunity and an option. And I thought that was really interesting.
Yeah, I agree. And Charlotte, any thoughts from your perspective?
And I agree with Taya as well, and it really excites me. My area is a big tourist area, so the patient experience, that's a huge thing for me. When I first started, patient experience wasn't necessarily a big part of care. It was, just taking care of the patient. It wasn't always doing the right thing. It was just, doing the jobs that you had to do. And so, that's the exciting thing for me as we go forward, making sure that we are doing the right thing for the patient, but that we are satisfying them as well, because they do have choices. They are shopping for the best prices, the best care, and it's based on how we take care of them. So that's very exciting for me to see that is a big, huge thing that organizations are looking at as well.
I know, I think about all the different possibilities. Now we've got these, pharmacy clinics that we can go to, or we're learning about some behavioral health that you can do online. I mean, I just think that the choices are now expanding, in a very rapid way. It's an exciting time.
I can even shop for my colonoscopy online.
It's just amazing the things that we can do now. So, in terms of, taking a look at the possibilities for data exchange and, thinking about, where we are and where we'd like to go, any suggestions for the, recommendations, thoughts, last minute thoughts that you can share with the participants on the call?
Just my closing thought is data exchange and engagement are critical to making the transition from fee-for-service to value-based care. If we want to have the continuity of care and all the stakeholders on the same page and executing a care plan, data exchange and engagement is just absolutely critical. I think we're making a lot of progress, but still have some work to do.
Hey, and Taya and Charlotte, before you provide your last thoughts, there's a question. What is your perspective on MIPS/QPP and specific tools that can help organizations move from FFC to value-based care? What is the general roadmap for this?
Sure, this is Taya. I can jump in there. So unfortunately, there isn't a general roadmap for moving from fee-for-service to value-based care. But there's a lot of stress around whenever you say MIPS and things of that nature to people. But I think what they don't realize is that if you break down those 4 categories in MIPS, one of them is pretty much PQRS, and one looks a whole lot like meaningful use, and then one of them doesn't really count right now. So there's not a whole lot of new. It's almost as if they've been baby stepping us into this shift to value-based care for a lot longer than we realized. So although there isn't a general roadmap, it's not as daunting as it might seem. Once you dive into it and start looking at what you actually need to do, chances are you're already doing a lot of it already. And because there isn't a generalized roadmap, we provide a lot of advisory services. I know a lot of other companies provide advisory services. The first step to do, and really my key recommendation, is to know what you have first. Do a self-assessment, do a SWOT analysis, do whatever you have to do to assess what resources you have internally, what margin you have in that operational budget to do more than you currently are, where you have opportunities to optimize your processes, and understand exactly what your workflow is and what you need it to be before you start looking at adding ancillary services and things of that nature to meet value-based care. And if you need support with that, there are a lot of organizations that provide advisory services that can help you with that.
And that's exactly where we started about 5 years ago. And we developed our own process improvement department to help all of our other departments with just what she said. And we found just exactly what Taya said. We found we were already doing a lot of those things. We needed to do it a little bit better, but we just all pull together and do that. But the big thing is just sitting down and analyzing what we're doing and how we can do it better.
So before you guys go into your closing remarks, one last question. Is there a tool that is both an EHR and analytics tool?
Yeah, this is Taya. I'm sure that there is. There are so many tools out there right now. And the only thing I would caution is please do your due diligence. I've been consulting for a long time, and that has always been the number one regret, is people rushing in to pick something out. Do your due diligence, ask a lot of questions, make sure that you understand what you're getting, get demos of the product, get references from people, because a lot of EHRs and analytics tools will claim to do a little bit of both, and a lot of them do it very well. So you just need to know for what you need them to do if they do that well. So make sure you see the product firsthand, make sure you ask questions. and make sure you get those references. But yeah, there's so much out there right now in the industry. One quick search will probably pull you up a handful of them.
Yeah. Yeah. Coming out of HIMSS a couple weeks ago, there's a lot of organizations that are staking the EMR analytics and even specialty EMR type propositions.
Well, just Taya and Charlotte, do you want to provide any last points to the participants?
Sure. Well, absolutely. I'm definitely a proponent for outsourcing things when you can outsource them. But I'm a practice manager at heart. That's where I started out. And so I would also advise you guys to do your due diligence. Just because you outsource something doesn't mean that you no longer have to pay any attention to it whatsoever. So make sure if you outsource something that it's being monitored and that it's integrated with kind of a regular cadence so that you know what's going on. If you're outsourcing something, those people should become your staff. You know, they shouldn't just disappear and become people you never see except at holidays. So just make sure that if you do decide to outsource something that you're keeping an eye on it. But that's all I have.
Charlotte?
I second what Taya said about the outsourcing, and we totally do the same thing and making sure they do follow what we need and doing the right thing, again, for our staff and our patients. You know, we may just that, but that's the biggest thing that we have to make sure that we're doing is taking care of our patients and doing those things, you know, to keep our organization going and being here to take care of them in the future. And sometimes that's thinking outside the box, and sometimes that's very hard for people to do as we go forward. And it may not look the same and feel the same, but in hospitals and care, that is, I always tell my staff, that is an ever-changing world every day. So get used to that.
Well, on that note, it's a little bit past the top of the hour, so I'd like to thank our fabulous panelists, Jeff, Taya, and Charlotte, and Nkosi for providing the overview, and also the people who participated and attended this webinar. And again, thank you so much to Availity for supporting this webinar. So I wish everyone a good rest of your afternoon.
Thanks, Claudia.
Thank you so much.
Thanks, everyone.
Bye, everyone.